Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities. The Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community.
Welcome to Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Spark Live is where we gather each Wednesday to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community with our goal to spark conversation, ideas, and action. Since we are live, I want to remind everyone that while we don't take questions over the line, you all have the opportunity to type your questions into the question box at any time. I will check for questions throughout the session, so please don't feel you need to wait until the end of the presentation before you start typing. Go ahead and put them in as you think of them. Also, feel free to share your thoughts on Twitter and be sure to tag us at Child Health Can and at CTN Kids. Today, we are talking about utilizing change management strategies to design and implement an innovative service delivery model for occupational and physiotherapy services. Children's rehab services are constantly struggling with increasing demand and operating costs without increasing funding. Innovative ideas and models are required to enhance service delivery for families, and change management strategies must be used to successfully implement those ideas. Today, you will learn of an innovative and occupational and physiotherapy service delivery model, the principles underpinning it, and the change management strategies used to implement it across 7 different service delivery agencies. I must say I'm intrigued by the F words in child development and look forward to hearing more about those, and the focus on functional needs, family involvement at every level, and coaching approach to therapy. Our speakers today are all part of the Children's Treatment Network, which supports more than 20,000 families in the York region and Simcoe County by providing specialized clinical and rehab services for children and youth with special needs through a network of contracted partner organizations in education, health, and community sectors. I'm pleased to introduce Kim Hesketh, Manager of Rehab Services at Children's Treatment Network, Mary Riggin Springstead, the Director of Program and Services for the Children's Treatment Network and responsible for all of their clinical rehabilitation and specialized services. And Lisa Spencer, a parent of 2 children with disabilities in multiple domains, a family member with Children's Treatment Network, and a member of the Family Advisory Committee. It's my pleasure to pass the mic to Kim.
Good morning. This is Mary Riggin speaking, and I will begin our presentation today. And I'd like to start by thanking everyone for joining us in this presentation. Before we go into detail about the OTPT model and how it came to be, we do need to explain a little bit about CTN, as CTN is not a traditional service delivery agency. CTN is an alternative model to a traditional Ontario Children's Treatment Centre. All CTCs, as they're known, provide rehabilitation services to children and youth, and they provide them in a traditional agency-based model. At CTN, as already mentioned, we service over 20,000 children and youth each year. Although the area we cover on our map looks small, which you can see compared to the size of all Ontario, it's a bit tiny. It's a small area, but it has a large population, and it's a significant component of the Southern Ontario population. Our core services cover York Region and Simcoe County with a population of 1.6 million people and almost 6.5 thousand square kilometers. In addition to that, we have for the past year started providing school-based rehab services in Simcoe and York, as well as to Toronto, which is another 600 square kilometer area with a population of approximately 3 million. Although we have not depicted this on the slide, CTN is also the Autism Spectrum Disorder Diagnostic Hub for all of Central Ontario, which includes Simcoe County, York Region, Halton Region, Dufferin County, Peel Region, and Waterloo and Wellington counties. So it's a very large area that we're servicing. CTN is primarily funded by the Ontario government through the Ministry of Children, Community and Social Services. You will see on this slide that in addition, we have some funding from the Ontario Trillium Foundation to support our Family Mentor program. CTN has a number of roles, which I'll outline for you. One is to provide system leadership to a network of children and youth service providers in York and Simcoe, to provide rehabilitation and specialized services to children and youth requiring those across our catchment area, to provide infrastructure support to support the provision of integrated local service, and to support capacity building across our network. CTN differs from a traditional CTC. We do not directly hire our clinical staff, but we host them in local agencies through contracting with appropriate local partners in health, education, and community sectors. This approach of hosting CTN clinical positions in other local agencies facilitates the integration of services. Integration of service is also supported by the provision of a comprehensive intake process to the service system, a shared electronic record that partners from all agencies document in, an integrated service plan to be based on the family's vision and goals, service planning coordinators for more complex cases, and the use of overarching clinical frameworks such as family-centered care and the F words of childhood development. Training to support the use of these tools and frameworks is provided, as well as training in select clinical areas to support implementation of current best practice. CTN also provides 10 local team sites across Simcoe County and York Region for clinical staff to use for service provision and to make services close to home and accessible for families. On this slide, you will see that we've carried over our box of providing services through partnerships with local agencies. Excuse me. These break down into two primary areas. We have core specialized clinical and rehabilitation services that we provide across Simcoe and York. In addition, we have the new school-based rehabilitation services, which CTN took on just over a year ago. This slide represents the list of CTN's core services provided in Simcoe and York. These services are intended for children with more complex needs. School-based rehab services provides rehab services in publicly funded schools. The population served by the school-based program varies by region, and the purpose of that service is to support children's ability to attend and participate in schools. The service we will be talking about today is our core OT and PT service for children and youth with more complex needs, not the school-based OT and PT, which, as I said, is new to us in the past year. We will be looking at evolving those services as a future project. To provide OT and PT to this core population, we contract with 3 hospitals, 2 school boards, 1 private therapy company, and 1 municipality to provide those services. These agencies employ their own frontline clinicians who provide the services on our behalf. OT and PT are only hosted in agencies that already provide OT and PT services to children and youth through other funding sources. This arrangement supports the integration and streamlining of service to reduce duplication. So that's an overview of Children's Treatment Network, CTN as we're known, and I will now pass it over to Kim to talk about why we undertook a review of our hosted OTPT services and how we went about that and what the outcome was. Kim.
Thank you, Mary. So the work on this project really began in early 2017. One of my responsibilities was to review the OT and PT services to ensure that we were providing equitable, consistent service delivery and that we were servicing the right children. We contracted, as we said, with those 7 strong partners to provide this service, which ranged from birth to school exit throughout our regions. However, we didn't have any overriding service model, which meant that the service delivery varied from place to place and with each agency. We started the project by spending a lot of time listening to our stakeholders. I sat with the Family Advisory Council and listened to their concerns and desires. We reviewed family and provider survey results for over the last few years, and I met with each partner OTPT team, and we held OTPT collaboration days, bringing all the frontline providers together. From all these conversations, the feedback was able to be categorized into 4 fairly strong themes. So 1, families needed a range of intervention approaches. A one-size-fits-all wasn't going to work. What is available through OT and PT needed to be clear, consistent, and transparent. And families and clinicians hated that discharge word. They hated being the possibility of being lost. The families needed an ongoing connection with the services with different levels of support at different time periods as their children grew and their needs changed. And we also found out that there was definitely more children with neuromotor disorders that would benefit from our services, but who didn't qualify with the current criteria. So once we had identified these major themes, we embarked on our change management process to improve our services. We decided to move forward using an approach based on John Cotter's change management model. The steps included demonstrating urgency, building a strong coalition, creating a vision for change, removing obstacles, identifying short and long-term goals, and then the evaluation and building. Our first step was to demonstrate the need for change. We needed to demonstrate the urgency with our stakeholders. We did this by engaging our key stakeholders, families, frontline providers, agency partners, senior leaderships, and spending a lot of time communicating why the change was necessary. We reviewed wait lists, outlined inequity of services for families depending on where they lived. We compared caseloads and service delivery methods between partners. We shared the thoughts and opinions of each stakeholder group with each other. We also highlighted the current provincial government and their views on service. And we highlighted any scientific evidence that we had that would support a change in practice. This was a big step for us. As a network, we have many stakeholders. We need to influence partners, families, and frontline providers. And we knew that in order for this kind of project to be successful, we needed buy-in from all of them from the very beginning. While we were talking to our stakeholders, we were also starting to build a strong coalition. This meant we were gaining senior leadership endorsement, but also identifying champions of the idea. We needed champions from various groups, including CTN leadership, partner leadership, from frontline, and from families. If we wanted to make the magnitude of change we wanted, we wouldn't be able to drive it from a small group of management within CTN corporate, nor could we even do it with just OTPT partner management. We determined in order to address the needs that we had previously identified, we were going to have to do 2 things. Change the eligibility criteria for children to receive OTPT services through CTN, and standardize the service delivery options and delivery across our 7 providers. Now that we saw that big picture change, it was about trying to imagine what it would look like. We needed to create a vision for change. We reviewed all that feedback we got from our stakeholders. We discussed and reviewed service delivery models, issues, current practice. We looked at what our other CTC partners were doing in Ontario, but also what other leading rehab centers in North America were doing. We looked at the literature and best practice, and from all of this information, we developed 3 different draft models. Each model had a different degree of change, as we wanted to get a sense of how much people were ready for. We reviewed these models with leadership and frontline staff, and based on those discussions, we formally adopted one of the proposed models to move forward and evolve. The first thing we had to determine was what we were going to do to address the eligibility issues identified. Our previous criteria was developed at the inception of CTN 11 years prior. The intention as the new organization was to address areas of needs that were not being serviced by other funders in the community. The criteria for OT and PT that CTN had used in the past was based on the need for mobility devices, whether that be a walker or wheelchair, or significant support with hand and arm use. We used the gross motor functional classification system and the manual ability classification system to determine eligibility. Both of these classification systems are evidence-based and supported by research. However, we have become aware that we were misusing them, specifically for children without CP, and that there were more children with neuromotor disorders who needed our service. Our parent presenter, Lisa, who's with us, was one of the families who were not serviced by our previous. Lisa, do you want to comment? Lisa?
Be muted. You might have to unmute yourself.
I do have Lisa's notes here, so if we cannot get her unmuted, Lisa, the little mic is on the top of the little webcam box on the right-hand side.
Oh, there we go. I was pressing the wrong button. I apologize. Okay, sorry guys. So as Kim had mentioned, we were receiving services through CTN. Our son has cerebral palsy. He wears ankle foot orthotics and is considered to be gross motor function classification system 2. He is mobile with some limitations. He frequently experiences pain and tires easily. We had an excellent team of therapists in place who provided support and care from infancy to preschool. However, once our son was school age, he was discharged and we were left without support. We were referred to a follow-up clinic, but the wait list was considerably long. We did not have any access to a therapist for a few years, and during this time, our son experienced multiple growth spurts. He was more active in play, and the physical demands at school and in the community increased. In fact, I remember emailing our former physiotherapist to ask if the stretches we were doing were still helpful, but she was unable to comment because she did not know his current needs or condition. We did not need or want regularly scheduled formal therapeutic sessions. We just needed access to information and reassurance that we were doing the right thing.
Thanks, Lisa. So after looking at our old criteria, the new criteria we came up with was that CTN would provide occupational therapy and physiotherapy to children from birth to school exit who have functional limitations resulting from neuromotor, neuromuscular, degenerative, or chronic musculoskeletal condition. This increased the number of children eligible to receive services. So for example, like Lisa's son, a child with CP who was able to walk without the assistance and was having an orthopedic surgery, such as muscle lengthening, would previously not have been eligible through our service. But now we would be able to see him and we'd be able to follow him as he continued to grow and address any other emerging concerns as they came up. It was time, after we have the eligibility taken care of, or at least a new definition defined, it was time to look at the second major change. In order to support the new criteria and to enhance our services, we developed the OTP Service Pathway, which would help families and provider understand their journey through the CTN services. We also wanted to ensure those services were consistent across CTN and in line with our intervention vision, principles, and beliefs. The ultimate vision of the new pathway is to optimize functional outcomes for children with special needs by providing the right intervention in the right amount, at the right time, and in the right location. The new model needed to align with principles that CTN stands beside. As with anything we do, we wanted to ensure that services were family-centered. Family-centered practice is a partnership approach to healthcare decision-making between the family and the healthcare provider. It recognizes that in most cases, the family is the one consistent factor in the child's life, and the family is the center of the child's life. It identifies and builds on families' existing strengths and emphasizes and promotes strengthening the parents' and families' ability to promote a child's development. We wanted our new pathway to be built around the F words for childhood development. The F words for childhood development are words that reflect some of the most important aspects of childhood development: function, family, fitness, friends, fun, future. They were first published in 2011 by Can Child's Dr. Rosenbaum and Dr. Hjorte Gorder, and are now used internationally when working with children with disabilities and their families. CTN wanted to support families and clients by focusing on the efforts throughout their journey with us. We wanted to ensure intervention was provided based on the functional needs of clients. We understand that clients and families have different needs at different times, and our intervention should change to reflect those needs. The intervention we provide also needs to be based and supported on evidence. And we wanted to ensure that our intervention was equitable for all families across the CTN geography, which included all of Simcoe County and York Region for these services. As CTN does believe in family-centered care and that the family is the center of any child's life, this means that they make the largest impact on that child. And for that reason, family participation in intervention is critical to maximize their outcomes. In order to ensure families and caregivers can use intervention strategies, coaching is a component of all our intervention approaches. In developing the system, CTN wanted to maximize our services and minimize duplication. We were not aiming to reproduce what already existed, and we also believe that families deserve to receive timely assessments and agreed to keep all wait lists to a minimum. So this is what the new service delivery pathway looks like, and I'll take a couple seconds to walk through it. So children and family typically enter the pathway from the left-hand side, which represents our early intervention programs, and then move to the right as the child moves into and out of school. Across the top are 4 intervention themes, which act as topic areas for focus and focus guides for families. The next level is our main OTPT program, the Growth and Development Program, followed by intervention options available at CTN. The bottom 2 gray boxes represent programs and community partners that may be involved throughout a child's development, have an influence on their OT, but are a separate program or organization. Using our new pathway, once families are referred for OT and PT, they enter the system through the new Growth and Development Program. This is typically a clinic visit at one of our CTN sites where they meet their therapy team. The team will lead them through a discussion, conversation to learn about their child, family, and the F words as they relate to them. They may complete a physical assessment if it's needed. However, if there's no concerns, and a full physical evaluation may not always be required. During the growth and development visit, the team will work with the family to develop goals and decide if any intervention is needed at that time, and if so, what it should look like. At times, families may need a lot of support, and the team will set them up with programs such as a group intervention, community assessment, and maybe a parent workshop. However, at other times, the family may express that things are going well and they don't have any urgent needs. The point is the intervention provided should meet the needs of the client and the family at that specific time. No matter how much intervention is provided between these visits, families will continue to be involved in the growth and development program until they leave CTN. When a growth and development visit is over, a family should know when their next visit is, or at least know who to call when and if they need one. Families can think of the growth and development program like a checkup with their physician. The frequency of those visits can change based on how the client and family is doing. Below the growth and development program, you will see all of CTN's intervention approaches. These include options such as activity-based intervention, which involves embedding therapy techniques into everyday routines, group programs, and episodic intervention, which provides an intense dose of therapy at key times. Therapists will work with families to decide what's best for them at the time. A more fulsome description of all the different types of intervention approaches and examples can be found on our website at www.ctnsy.ca under the Program and Services tab in the Intervention Guide. So once we had decided what we wanted the service to look like, we needed to identify and remove as many obstacles as we could to get it into place. So we did this by creating opportunities to engage regularly with our frontline providers and for providers to network and learn from each other. We increased training opportunities for providers and families. We identified acceptable variances in performance targets for our agencies as we rolled this out. We adapted our documentation templates. We created an intervention guide, which I mentioned earlier, so that there's some clarity and transparency about what was available. We also created new intervention groups as we anticipated the number of children we were servicing to increase, and we adjusted the use of the rehab assistance to support the model. We also created a few different family communication and education opportunities. Sorry, I was a little slow on that next switch. So now that we were all designed and we identified what we were going to do, we had to decide how we were actually going to do it. How were we going to implement the program? We created a detailed implementation plan where we identified our short-term wins, but set aggressive and realistic targets for down the road, such as the rollout dates and evaluation timing. And we committed to evaluating the model. We agreed to a plan, do, study, act cycle and supported this. To support this, we created a logic model and evaluation plan with our analyst. We launched pre-implementation surveys to parents and providers and determined to redo them again at 1 year. And we determined what statistics we were going to monitor throughout the year. So our evaluation framework involved short, medium, and long-term outcomes. It involved looking at things such as capacity, satisfaction, professional guidance, goal setting, access, efficiency, and leadership. This outlines our timeline of from the beginning to now. The planning, as I mentioned, began in early 2007, and then we actually started our stage rollout in September of 2018. So we are now fully implemented and just over a year into our new system. So being a year in, we did want to show you some of our year one outcomes. So the most important to us is obviously our families. So we wanted to start by letting Lisa tell you her story and her experience with the new program.
By the time our son was eligible for the follow-up clinic, the therapist needed to do another full assessment. He hated the idea of infrequent visits to therapists because a great deal of time was spent on discussing his needs and very little on discussing his strengths. On one appointment, he actually refused to leave the van, and I remember him saying, "I don't want to go in because they're just going to tell me what's wrong with me." He was so stressed about the whole process that he wouldn't let go of my arm. He knew he would have to walk up and down the hallway while other people stared at him. He already knew he walked differently than most people. What he wanted was supportive solutions to the issues that were important to him. He wanted to feel accepted. So we recently had a PT-OT session under the new service delivery model. And at first he was guarded and closed off, but the tension in his shoulders released once his therapist started engaging him in conversations about his interests and his goals. He told her that he wanted to keep up with his friends. He told her that he used a recumbent tricycle to play tag because he gets tired. What he wanted was a wheelchair for long excursions, and he wanted to know how accessible it was to take on school trips. Once we had a plan, he was more than willing to walk the hallway and do the treadmills. He understood the purpose, and it was important to him. The F words helped him see his own strengths, advocate for his own needs, and feel accomplished for participating in the decision-making process. When we returned to test drive that wheelchair, he was more than eager to participate fully in the entire appointment.
Thanks, Lisa. Looking at some of the more statistical outcomes, we've also seen a decrease in our wait times. So we had a mean decrease. Remember, we have 7 agencies. So they all have their individual wait times of a decrease of 36 days from referral to first visit. We had an increase in the number of clients that were seen per full-time equivalent position. Again, a mean of 3.7. We did see a decrease in our service recipient minutes per visit of 11 minutes. And we also saw a decrease in the number of total visits per client. So that include email, phone, face of just over half. But interesting enough, when we broke those down, there was no change in the number of face-to-face visits for the families. In our family questionnaire, unfortunately, we did see a decrease in family satisfaction and perception of the family-centered care as measured by the MPOC, and the numbers are there. So anywhere from minus 0.13 to minus 0.7 or 0.67, with a 0.5 being clinically significant. And although this is disappointing, it's somewhat understandable with the amount of change that we put our current families through, as well as it's highlighted for us what we need to spend our time doing over the next year. We went from a traditional model where there may have been a lot more weekly, bi-weekly kind of visits or service approach to more of a coaching model. And perhaps we needed to spend a little bit more time explaining to the family why we chose that coaching model. There was an increase in clinicians' feelings of being overwhelmed by their caseload, but again, due to the significant amount of change we threw on them in the span of 1 year, that is not surprising to us. What was, though, was that, well, not surprising, but what we did like to see that there was an increase in service provider satisfaction, even with all this change. And the clinicians were still able to meet the needs of their clients, and they were able to maintain the impression they had of equity across the service. One of the outcomes we're quite proud of is the use of the F words for childhood development. So although it was only one component of our model and one of our values, we saw an increase of 31% of our providers using it during intervention and planning, and a 50% increase in it being used with conversations with families. During the first year, one of the great things that occurred was that we developed multiple new programs in order to support the new kiddos coming in and support the new model. So we started a new modified constraint-induced movement therapy program, a drop-in at the park, parent participation program, Great to Participate, which was another group option. This one for our kids between kind of 4 and 7 who are a little more high functioning from a gross motor, fine motor point of view. We had a drop-in fitness program that we called Keep Moving. We also started Yummy Tummies, which is a feeding group that ran during March breaks. And we developed 4 different parent education modules, and we hosted 2 different parent webinars to explain and outline kind of the new model and what it entailed. So now we sit here in 2020, and we will continue to use the PDSA cycle. We'll continue to evaluate our outcomes, and then we plan to implement changes on the model and the criteria based on the evaluation results that we get. So as much as it was just the 3 of us speaking today, we want to emphasize that it's really the work of our hosted partners that made all of this possible. We facilitated here at CTN, but our partners Closing the Gap Healthcare, Aurelia Soldiers Memorial Hospital, Royal Victoria Regional Health Centre, the Regional Municipality of York, York Catholic District School Board, and York Region District School Board were really the providers on the ground rolling out this change, and their management supporting them. So a huge thank you goes out to them for making the first year a success. So that's all we have for now. I'm happy to answer questions for the second half of our hour.
Thank you so much. That was very interesting. We have a question here in the question box, but I'm not sure if you've answered it. To the extent that someone wanted, what degree of change, low to high, did the selected model involve?
It was the medium. So I think they were talking about those 3. We had identified or rolled out 3 different models, or proposed 3 different models, one with minimal change, one with moderate change, and one with significant change. And the one that was supported was the moderate one. So enough change that they had to change their day-to-day routine, but not enough change that we were changing funding and support and FTEs and that kind of thing.
Another question, do you have a sense of how your services are experienced by Indigenous families and children?
Yeah, that's a great question. CTN is quite engaged in that area quite a bit, and definitely up in Simcoe. We service Christian Island in a few different areas. But I have to say, I don't know that our OTPT evaluation that has been rolled out, if we're able to separate that information specifically from that. It's a very interesting thing that we should probably add to our year 2 evaluation, though.
Wonderful. Another question, how did you measure the use of the 6 F words?
Yeah, so that was provider reported. So at this point, we didn't have the ability in our electronic record. School-based rehab was also rolling out for our agency at the exact same time. So we had 2 major initiatives going. So we weren't able to pull it electronically quite yet. So we collected that data on provider report from our provider survey. Hopefully going forward, the efforts are embedded in some of the documentation templates that we have on our electronic record. And hopefully going forward, we'll be able to pull that to get a more systematic, kind of accurate count.
Great. Another, how are you willing to share your coaching model and resources for families?
Yeah, I mean, we're definitely willing to share anything we have. Our coaching, we have not chosen a specific, I know there's a few different coaching models out there. We have not chosen one specific one to go with, as opposed to supporting the philosophies that go behind or go with most of them. We've ran an education day for all of our OTPTs in which we had a panel come, and we invited speakers from a variety of different places in Ontario. Some were early interventionists, some were therapists, but some were also CDAs. So it wasn't just OTPTs who were speaking, and they all kind of spent a good amount of time explaining the models that they were using of change, and then they explained their journey from the kind of resistance at the beginning and how hard it is to some of them were 10 years into a coaching model and how big of a champions they had switched to. We've also identified from our year one evaluation that we do need to do a little bit more robust training with our coaching. We found that people actually thought they were using coaching, and then we kind of introduced it and then realized perhaps they weren't actually using it the way that we intended. So we are going to spend some time in our year two providing or trying to find that education for our OTs and PTs.
I think that's a really interesting finding and not at all uncommon, whereby you're implementing something, but the thing that gets implemented and the idea that was intended are not always the same thing. We've got a lot of questions. I'm delighted to see the amount of interest here. So we're going to proceed through them. How are you assessing and supporting the safe transportation of children? This poster said, I noticed that there's education on safe feeding and a gross motor group. Do families feel educated in their options and supported?
So can you say that one again? Was there two questions there? I think
there might be, yeah. So the first is, how are you assessing and supporting the safe transportation of children?
Okay. That one, so to be honest, I don't know that we are. We provide our services in a variety of places at our sites, in the community, and at the schools, if that's where the appropriate place is. However, our therapists have not been involved with actually the planning or the getting the kids to and from. So if that's what that question means, I have to say we have not been involved with that yet.
And the second part of the question may in fact be related, which is, I noticed that there is education on safe feeding and a gross motor group. Do families feel educated in their options and supported? And I'm going to assume that that's around the safe transportation, but I could be wrong.
Yeah, I think maybe if that person wants to throw a bit of a clarification in the comment box, that'd be great, so that I make sure I answer it for them. Perfect. In terms of the parents knowing their options and feeling supported, that's what we have our intervention guide for, but that definitely doesn't address the transportation kind of issues. We try to rotate our groups throughout our 10 sites. So that, depending on the population, so that we can provide the services in the different communities. So long transportation isn't an option, because you can imagine driving from one end of our geography to the other would take quite a bit of time. And we stress with our therapists to ensure the families know what options are available to them. And that's why we wanted to make that very transparent by putting the implementation guide out there. But I'm not sure I've answered the question for that person, so if they don't mind any clarification, that'd be great.
So she typed a clarification. I'm asking more about the way that families safely transport their children who may not be able to use car seats or booster seats in their own vehicles.
Yeah, no, we haven't addressed that one through CTN yet. I know I work with the Empowered Kids Ontario Best Practice Group, and this has come up a few times on a provincial level. And we've started to collect a little bit of data there. But CTN specifically, we have a seating and mobility team who would address these questions specifically from a family. But outside of that, we don't have anything specific. So I don't know how our families feel, to be honest about it.
Okay. Do you offer speech and language services?
It's Mary. I'll address that particular question. So as an agency, I spoke about our core services versus our school-based rehab services. Within our core service, the only speech language pathology services that we offer are around feeding and around augmentative communication. We are a general level clinic under the Ontario Assistive Devices Program for the prescription of augmentative communication devices. So our core services are concentrated on feeding and on augmentative communication. With the acquisition of school-based rehab services at the end of 2018, we have taken on a new mandate around intervention, speech intervention for school-aged children. Ontario has an interesting system in that language and mild articulation challenges for kids are the responsibility of the school boards, but moderate to severe speech production and voice and fluency disorders are the mandate of the school-based rehab services. This mandate split has been in place for decades, and from a speech language perspective is challenging. So we do provide those services for the moderate to severe speech and fluency and voice. And the specific mandate of the school-based rehab services is to ensure that children are able to attend and participate fully in school. So yes, those are the services we provide.
Thank you, Mary. What is your referral criteria, or what are your referral criteria and intake processes?
So we have an central access for intake. So we have an any door is the right door policy at CTN. So referrals can come from parents, providers, physicians. Really, we are not picky on that whatsoever. Our criteria, so when the referral comes in, they come into our access team, who then connects with families, opens a shared record that all of our partners can document in, and adds the different appropriate teams and kind of sends out that notice. The referral criteria we use now for OTPT is not completely open to anyone. We did blow it open quite a bit with the new criteria. So it goes back to that statement about functional limitations resulting from neuromotor, neuromuscular, degenerative, or chronic MSK conditions. And right now our chronic MSK conditions are defined mostly as osteogenesis imperfecta, limb deficiency, and there may momentarily blanking, of course, on the third one, but the arthrogryposis. So kind of those MSK conditions that have kind of long-term implications. We're going to continue to look at this. We don't have, so this model did not come with any change in funding or FTE. So we had to look at our criteria and how broadly we open it in kind of a stage approach. There also are other providers in funding in the region that address different populations of kiddos. And CTN really wanted to fill the gap.
It's Mary, I'll just add to that. In terms of our who we see in across CTN, Kim's spoken specifically about our core OT and PT. Our mandate is children and youth, birth to school exit. As Kim has indicated, we have open referral from with parent permission from anyone who's working with the child. There are some services that do require physician referral because of the way what that specific service is for. All of our services, which is a little bit complicated for families in our system, have different eligibility criteria. So Kim has spoken about the OTPT, but different services have different eligibility criteria. Kim has also referenced our access department, and our access team is a great team. It's a multidisciplinary team that processes the referrals, does a child and family interview with the family. Sometimes we don't have the service in our mandate that child is needing or that family is needing, but our access department is fully versed on the services in the regions, and then we'll facilitate a warm transfer of that family to another service if they're the provider of the service that that family needs.
And by warm transfer, is that they don't end up on another wait list, or?
No, it's they would, if they had called that agency directly, they would have ended up on their wait list. So it's not about the wait list per se. It's about simplifying the process for families and offering them options. Some families just really want to know, oh, I should call there, and they want to do it, and that's fine. But we will actually transfer referrals over to another agency on behalf of the family and share our information, which is of course in our shared electronic record for that partner agency to access. So we're trying to make sure that, you know, if the families get to the CTN access number, we can get our child and family interview. It does a comprehensive identification of needs. Maybe they've called for OT, but it's very clear from that interview they need speech, and say it's a preschooler. We will facilitate their referral over to the preschool speech and language program, which is in another lead agency. So it's a support that really works well for families, helps to identify needs, all needs at the time of intake, so that we don't have the issue of cascading waiting lists, where the child's put on a list for one thing, is seen, and then that therapist says, oh, they should also be on the list for X, and they wait again. So it's a streamlined intake process.
Yeah, and they don't wait for that family interview here, really. Like it's a very quick turnaround. So it's not like they're waiting here and then they wait somewhere else.
Okay.
It's fairly immediate.
There are many more questions that we'll continue to work our way through. Would you be willing, if we run out of time, for me to send you those questions and we can upload them to the Knowledge Exchange Network for folks to see?
Yes, of course.
Absolutely.
Okay, wonderful. The next question is, can you describe how the CTN model addresses access in rural areas where families may not be able to physically get to an agency?
Yeah, so we are very clear that if that is the case, then our therapist can go to them. We do have some areas, I'm sure not remote as some of our northern areas, but we up in Muskoka, or up in Simcoe, we do get families who have challenges getting to sites, and that is why we have no issue whatsoever for our therapists to provide those services in the home, if that is a family limitation. So no family would not receive service because they can't get into a site.
And I will mention, I mentioned at the beginning that we have 10 local team sites, and those have been, that was one thing we heard from families in the planning for CTN before it launched, was that families wanted services closer to home. And so instead of building one big building in one central area in the geographical region that families would have to travel to, we provide 10 local team sites in those communities, logically placed in certain geographies of major towns, that are equipped for provision of services. And in the for OTPT, each of those sites includes a gym. So we still have limitations for some families who can't get to that site, but by placing them in the local areas, we've minimized that travel for families, and some workarounds can often be found to get families to those sites.
Completely. Even in our more rural areas, at the most, it's usually 20 minutes, half an hour to any site at the far end. So.
Okay, thank you. Another, what percentage of your referrals are for children 0 to 4? And next part of that question is what percentage are children diagnosed with autism spectrum disorder or with CP?
So I'll start with the second half there. So co-diagnosis of autism and CP, I would have to look at our stats, and I can probably pull that for you, but I don't have it off the top of my head. So children with children who only have a single diagnosis of autism would actually not qualify for our OTPT services. Those services are provided by an alternate funder or agency in our area.
With the exception of in our school-based rehab. This is where our system gets very complex. In our school-based rehab, children with autism spectrum disorder would be covered through that program for school-age children, but for preschoolers, it's another agency.
And in terms of our numbers for school age versus early intervention, I would have to look at referrals, but because our kids come in at early intervention and then carry on throughout, we obviously have less referrals for school age, but we're transferring all those kiddos from early intervention to the school age teams at the entrance of JK. And again, that's the actual total numbers. I have numbers per FTEs and stuff like that. But total clients, I would definitely have to look up for you. My anticipation is that it's fairly even between the two groups when I look at FTEs and providers and that kind of thing, but I would have to look that up. But if we can throw that in the questions that are left over, I can pull those stats for you. Sure.
I think I might add some context as well. When CTN was very late to be added to the Children's Treatment Center system in Ontario, and in fact launched only in the mid early 2000s. So as a result of that, the absence of having a children's treatment center in Simcoe in York had led many agencies who are now our partner agencies to put services into place to fill a gap, whether or not those services were or were not really their core mandate. So when CTN came along, the planning for CTN reflects what CTN is today. It was a very collaborative community process involving families, involving partner agencies, etc. One of the key messages we heard from families and partner agencies in this process was, do not duplicate. We need specialized services. That's what we don't have locally. That's where we tended to focus. And what had happened in the system development over the years was that more resources had gone into preschool from our partner agencies than school age. So as a result of that, CTN has kind of a heavier weighting on school age than preschool services because they existed elsewhere in the community due to the delay in the acquiring of a children's treatment center for Simcoe in York.
Thank you. Another question, how have you managed frontline provider satisfaction with the change process and the evolution in their practice? What's their adaptability to change?
Yeah, so that's a great question. I would say their adaptability to change ranges from people who couldn't understand why we weren't there already to a few that still have heels kind of in the ground. We made that a focus from the beginning by engaging in them with the very beginning. So even before we created any kind of model, the first kind of step really was that we called them all together, which didn't happen a lot, right? Because they're employed by 7 different agencies. We called them all into a room, held a day for them, and just collected their thoughts, opinions, everything they wanted. And then every step of the way, we went back to them. So we now pull them together from all different agencies twice a year. And every kind of change or thing that we're going to adjust to the model goes through kind of that meeting with all of them. So they kind of get their opinions and thoughts out there. And I think we're very cautious or aware that we need their buy-in for this to work. They are the ones doing it on the ground. So we try to give their thoughts and opinions a lot of weight from the beginning. And it's a slow process. I would have liked to switch in 3 months. As Mary knows, I like my quick change, but I've learned to be patient over the last kind of year and a half, and it's more and more and more we're seeing a change. But I think the biggest thing is that we involve them from the beginning, and they were involved in the design, and they continue to have a voice.
Thank you. Are the centers fully connected with the OHTs, the health team?
So it's Mary. I will answer that question. As in Ontario, the government is in the initial stages of the transformation of the healthcare system, and what are known as local Ontario health teams are being formed across the province. From a CTN perspective, we are currently, there's a number of Ontario health teams, as you can imagine, across our vast geography. We are currently in conversations with those particular health teams and trying to determine CTN's fit with the Ontario health teams in our regions. At this point in time, the majority of those health teams are highly focused. They have to determine target populations for the first year, and many of them are focused on the frail senior populations as their primary focus in the first year, which of course is not where our mandate sits at all. So what we're doing is we're engaging with them, we're establishing relationships with them, making sure they're really well aware of what our services are and where we have the overlap and where we might connect. And we're receiving a very positive response through our discussions with Ontario health teams. I had one this morning, actually, before this webinar, and just ensuring those connections are there as we start to move into the children's planning pieces, and figuring out our exact fit depending on what each individual team is focused on.
Great, thank you. We'll take one last question and then the others will send off to you and post your responses. How are you able to ensure fidelity to the model or approach given the multiple service provider agencies?
Very, very good question, and a nice, easy one to end off on. Thank you for that. Yeah, so measuring the fidelity is definitely a challenge. We are closely tied with the 7 managers of the different agencies. So we're constantly in contact with them, in conversation on how their team is doing with it and how they're running it out. In the provider model, provider questionnaire, there's also some questions specifically around that, how they're doing it, and if it kind of matches with the purpose. It is something I think we will need to take a more kind of prescriptive evaluation look at going forward, especially as time goes on. You know, at the beginning, everything is so kind of concrete and clear and everyone's just learning the same thing at the same time. But as it goes on, we're going to have to look at how we sustain that, what I think is fairly good fidelity right now based on the surveys and stuff we've received back. We have taken a few different steps, like ensuring anyone new into the system gets kind of a orientation to the model. We have the video in the descriptions fully available for parents and well as providers so that parents can see if they're getting what is described on there as well. So I would have to say, unfortunately, it's probably a little bit of a roundabout way, but our evaluation analyst is doing this with us in another project, and it's something we should probably look at more in depth for year 2.
Great, thank you so much. We're at the end of our time. I wanted to thank you again, Mary, Kim, and Lisa. Children's Healthcare Canada hosts the Spark Live webinars every Wednesday at 11 o'clock Eastern Time. It's always great if you can watch live, as your questions and comments really enrich the discussion, and this discussion today has been quite rich. But if you can't watch live, the recordings of these sessions are made available after the fact on the Knowledge Exchange Network at www.ken.childrenshealthcarecanada.ca. Our next webinar on January 29th will feature Partnering for Pain, 10 Priorities with Dr. Katie Burney and Catherine Dibb. This webinar will be provided in partnership with Solutions for Kids in Pain, a network of networks of Centers of Excellence knowledge mobilization program to improve children's pain management by mobilizing evidence-based solutions through coordination and collaboration. To keep up to date on our webinar schedule and other Children's Healthcare Canada events and activities, please sign up for the Spark newsletter. To do so, simply go to childrenshealthcarecanada.ca, scroll to the bottom, and enter your email address. Easy peasy. So thank you again for joining us today. Hopefully we'll see many of you back here next week. Bye, everyone.